The next patient will be presented by Dr. Santini. I thought you would help me.
Okay. This is a patient with a family history completely negative for any hematological neoplasm. He had nothing really relevant, but he started presenting a mild anemia that worsened quite rapidly. It was a microcytic anemia, and he had all the other value in normal range. When a bone marrow aspirate was performed, he had a hypercellular bone marrow, and there was a clear diagnosis of MDS with 60% dysplasia in the erythroid lineage and ring sideroblast higher than 50% with the trisomy 8 at karyotype, no fibrosis. And he had also, well, his borderline spleen size a little bit augmented. So do you think I have missed here something in the diagnostic procedure of this patient? This patient actually was managed in a small hospital, and he got EPO as therapy for the progressive anemia. He was classified at that stage with only IPSS, was an intermediate one risk, and he had a good response, slow but good response to EPO. And then he, little by little, lost response to EPO. He increased the dose to EPO twice a week, and then he completely lost response and became transfusion dependent. And at that stage, he came to our center where he was reevaluated. He had 90% ring sideroblast, still only trisomy 8, but he presented also mutation of SF3B1 and DNMT3A. So he scored with IPSS-R 4, an intermediate risk, and we noticed that total bilirubin was very high, so we tested him for mutation of the gene UGT1A1, and he was diagnosed with Gilbert syndrome. We proposed him the inclusion in the protocol luspatercept versus placebo. He accepted, and he started receiving the drug at 1 milligram per kilogram. You see that his response was present. There were some oscillation with hemoglobin levels. He repeated only once a transfusion, and in this case, we increased the dose of luspatercept. And then he maintained a decent transfusion independence. Then again, after, as you see, a couple of years, he needed a transfusion again. Then we increased the level of the dose of luspatercept, got a response again. That was a little bit less well maintained in the beginning. But in the end, he could maintain a good level of hemoglobin with peak above 10 gram deciliter without any further transfusion. So in 2019, after 39 cycles of the drug, we reevaluated the patient because he was again a little bit anemic. He had an increase of ferritin that we saw increasing over the months, and the appearance in the bone marrow and the cytofluorimetric and morphological analysis of mastocytes with an aberrant expression of CD25. The other lineage were still stable. The ring sideroblasts were still 80%. The marrow was showing at the biopsy 1% of CD117 and CD25 positive mastocytes, still only trisomy 8, but there were a little bit more mutation, JAK2, TAT2, and the already observed SF3B1 and DNMT3A mutation. The tryptase was 166 milligram liter, and the mutation, KIT mutation, was negative. So would you modify the treatment approach of this patient given the occurrence of mastocytosis? What would be your diagnosis? And what did we do? We actually kept on treating the patient with luspatercept, but then we lost response and needed transfusion with an increase in burden. So the patient is transfusion dependent with 4 red blood cell units in 4 weeks. He, of course, is stopped luspatercept. In the end, what we had with this patient, he responded from 2016 to 2020 for 207 weeks, and he's receiving at present only supportive care and iron chelation. He had no further increase of mastocytes, but his general condition worsened deeply for neurological and cognitive impairment, and we are still evaluating what to do to treat this patient who is severely transfusion dependent.
So I think, one, it's interesting that one point that the case illustrates is that if you start to fail at one dose level of a luspatercept, you can increase the dose and still obtain a response. And you got a long response out at almost 40 months with this patient.
40 years, 4 years.
4 years, yeah.
Yeah.
So, but typically patients have slow progression and onset of worsening marrow failure over time and start to fail their therapies. And so I think the data from the presentations this morning have shown that alternatives, lenalidomide, hypomethylating agents, and imetelstat, other options are considerations for these patients. And I think the acquisition of additional mutations suggests that the MDS is worsening. I'm not sure that this low level of mastocytes is contributing to the anemia at this point, and I don't think aiming therapy at that would be effective.
Okay. Yeah, I agree with Dr. Silverman's comment. And considering the occurring co-mutation of JAK2 and TET2, those two seems to contribute to the losing responsiveness to luspatercept. This gentleman is 66 years old right now, and if he has very heavily transfusion dependent, transplant may be a choice for the next step. That's my comment.
Yeah, the only obstacle we have now are his general conditions that are a little bit, well, especially for the neurological part, are really putting us in trouble because we don't know whether we can offer transplant.
I agree with the major points already made by my colleagues. So the only thing I'll add is with the KIT mutation analysis, sometimes there can be a false negative when you have these mastocytes. So the number of cells may be low. In addition, just regular NGS for KIT may not be sensitive enough, so others have suggested doing digital droplet PCR or more sensitive methods to really find that either from blood or bone marrow. So I don't know that it's totally relevant to this exact case, but that's just one thing to consider if you have other cases with mastocytes.
Thank you so much. I'm sure we could continue, argue, and debate, but we have to close the session. So thank you, the expert panel. I would like to thank my co-chair, Professor Valeria Santini. I would like to thank you for coming here early morning and attending till now. I would like to thank the MDS Foundation team, especially Mrs. Leah Harrison, who really worked very hard to make this session happen. Thank you so much. Enjoy ASH.